Bismillahirrahmanirrahim. Over to Professor Rashid Saab for the recitation of Holy Quran.
Bismillahirrahmanirrahim. Fazkuruni azkurkum washkuruli wala takfurun. Fazkuruni azkurkum washkuruli wala takfurun. يا أيها الذين آمنوا استعينوا بالصبر والصلاة إن الله مع الصابرين. शुरू अल्लाह के नाम से जो निहायत मेहरबान रहम वाला है। और तुम्हें वो बातें सिखाता है जो तुम नहीं जानते थे, लिहाजा मुझे याद करो, मैं तुम्हें याद रखूंगा। और मेरा शुक्र अदा करो और मेरी नाशुक्री ना करो। ऐ ईमान वालो, सब्र और नमाज से मदद हासिल करो, बेशक अल्लाह सब्र करने वालों के साथ है। सदक़ल्लाहुल अज़ीम।
जज़ाकल्लाह प्रोफेसर राशिद साहब, आपका हमारे साथ बड़ा अरसे से सफ़र है और 2021 से वो स्टार्टेड दिस जर्नी विद द हेल्प ऑफ प्रोफेसर Salma Kundi. Thank you so much, Professor Saira, Salma Kundi, for you are always input as educational leader. और आप शायद ना होते तो मैं इस सफ़र को शायद ही कहीं कब का छोड़ चुका होता। और फिर इसके बाद इसको वो स्टार्टेड और उसके बाद हमारे साथ साउथ एशियन एसोसिएशन ऑफ फिजियोलॉजिस्ट भी मिल गया, फिर पाकिस्तान एसोसिएशन ऑफ पैथोलॉजिस्ट भी हम हमारे सफ़र में शरीक हो गए। वुमेन मेडिकल एंड डेंटल कॉलेज तो पहले हमारे लीडरों में से थे, और इसके बाद पिछले साल से वुमेन मेडिकल एसोसिएशन ऑफ पाकिस्तान वो भी हमारे सफ़र में शामिल है। बहुत इंपॉर्टेंट टॉपिक है आज का, साइकोलॉजिकल फर्स्ट एड, और उसके अंदर जो है प्रैक्टिकल गाइड फॉर प्रोफेशनल्स एंड एजुकेटर, स्पेशली मैडम सलमा, वो जो आपकी तरह लीडर हैं और जिनके यहाँ आजकल इश्यूज ज़्यादा आ रहे हैं। तो आई अटेंडेड दिस लास्ट टॉपिक वेबिनार विद प्रोफेसर साइमा रफ़ीक एंड प्रोफेसर साइमा बतूल एंड नाबगा, एंड आई रिक्वेस्टेड कि आप भी हमारे पीएमए के वेबिनार के ऊपर एक इस तरह का वो कर दें। तो प्रोफेसर साइमा रफ़ीक ए वेल नोन मेडिकल एजुकेशनिस्ट भी हैं, बेसिकली तो ये गायनोकोलॉजिस्ट हैं, प्रोफेसर ऑफ गायनी हैं, तो चेयर हैं एफडीपी की, यूनिवर्सिटी ऑफ कॉलेज ऑफ मेडिसिन की, यूनिवर्सिटी ऑफ लाहौर की। बड़ा लंबा सफ़र है, बहुत बड़ा नाम है, और ख़ुद मैं अब इनसे खुद सीखता हूँ। जब मैं बैठता हूँ, जब इनकी कोई प्रेजेंटेशन होती है, मैं खुद इसमें से लर्न करता हूँ। प्रोफेसर साइमा बतूल, सेम नाम नकवी, और बुनियादी तौर पे प्रोफेसर ऑफ पीड्स हैं, मेडिकल एजुकेशनिस्ट हैं यूसीएमडी की, और इनके साथ भी नेशनल इंटरनेशनल बहुत सारे मैंने फोरम पे अटेंड किए। आई एम प्राउड ऑफ दिस कि मैं भी डॉक्टर साइमा बतूल आप लोगों से सीखता हूँ, क्योंकि सीखने की कोई उम्र नहीं होती। और हमारे
थैंक यू
दरमियान
सर।
एक बहुत ही नौजवान बच्ची, नौजवान स्पीकर, और मेरे क्लास फेलो की बेटी है, एमबीबीएस में मेरे क्लास फेलो थे। तो बड़ा अच्छा मैंने लगा, और माशाल्लाह इनकी तरक्की को देखा, डॉक्टर नाबगा, और इस वक्त ये यूके में है। तो ये इंट्रोडक्शन था, और इसके बाद मैं ये सारी कहानी जो है, ओवर टू प्रोफेसर साइमा रफ़ीक, शुक्रिया के साथ, ओवर टू यू और
जी सर।
नॉट, यू लीड द प्रोग्राम जब तक ये वेबिनार चलेगा, यू आर नाउ लीडर।
चलें ठीक, थैंक यू सर, थैंक यू। So everyone can see the screen?
Yes, yes.
Yes.
जी, Bismillahirrahmanirrahim. Thank you so much, sir and Madam Salma, for having us on this webinar. And I will basically discussing why we need this, why we have to learn psychological first aid. Okay, can you see the date of publication of this article? This is July 2022, exactly roughly 4 years ago, when this person claimed that this would be an epidemic and the Pakistan should be prepared for this epidemic. Why Pakistan should be prepared for this epidemic? Because we have 55% of population that is below the age of 25. These are the stats from 2019. And I will just concentrate on a word, 70%. Approximately 70% of the deaths were between age 15 and 29. Okay, now come to the burden of mental problems. So, 1 in 4 student, overall population में 1 in 4 student is in some sort of psychological distress. When we talk about the MBBS profession or health professional education, we are at double risk of suicide as compared to rest of population. And being clinician, we all know, or being involved in MBBS curriculum, most of us, or maybe some of you are involved in education. Just so you can see what are the risk factors. The chronic sleep deprivation, we all know, emotional fatigue, and I personally feel these two factors, which I will now say, the high expectation from family and society, and a perfection culture in medical training, these are actually the two main contributors to burnout, anxiety disorder, depressive symptom, emotional detachment, and then maybe some of the doctors may with end of their life. So let me say this: we train our doctor to treat other, but we do not train them to protect their own mental health. This is an article from postgraduate anxiety rates, and you can say the prevalence of high rates, and we all know the postgraduate training, they are actually struggling their lives. And we in that training or so, what we found, as we have been trained in the same setup, same FCPS trainings, that the stress is often normalized as a part of training and is not recognized as health concern. Okay, so let's see, and let's have an idea what are the primary stress drivers. Yes, academic pressure. Have you ever seen the list for MD-CAT students? Have you ever seen the list where the merit for KE closed? And it's honestly in public sector, the merit close for the medical college of even DG Khan at 90%. So the academic pressure is there. Then there is the prevalence of family disputes or maybe family disagreements also. And the last thing, which will be more common, and I guess you all may agree, that is excessive use of social media. So what this social media is doing to our generation, it's a sort of double-edged sword, in a form that we all need social media to connect. But the overuse of social media do link with mental health problem. So the negative impact include the social media do create a constant comparison or a constant competition. Then obviously some of the forums like LinkedIn or so, they do add to the academic pressures. One of our student shared with us that if we look at the LinkedIn profiles on daily basis, I do get stressed. Then doom scrolling is basically when you scroll for the negative comments or a bad news repeatedly, and you keep on scrolling the social media, and this will lead to sleep deprivation. Another thing which I personally feel, that even we as an older generation, or maybe not the Gen Z, we are also suffering from a phobia that is called nomophobia or nomophobia. So no mobile phobia. So this no mobile phobia will compel us to check our mobile again and again, and it will inhibit to our ability to concentrate. This thing we all are familiar, that that we have a culture of silence. We have a fear of labels like loser or sensitive, and we do not seek help for our mental problem. And for PGRs or even for doctors, health work overload. And in that overload for PGRs, we do have some calculation that they should not work for 80 hours or 60 hours. But what about the consultants? Are they being paid at one place that they do not have to rush for the private practices or so? So at times it's a 24-hour practice, and they don't have the time limits. So, what are the pillars of stigma? I personally feel there are 4 pillars of stigma. One, at the institutional levels, we never allowed the faculty even to discuss the problem, or if they are having any mental, you can say, psychological problem, issue, or even a very minor form of anxieties. Then there is social platforms, then self, and then from parental. So when I would be discussing the last slide, one of you, or maybe all of you must be thinking, ऐसा क्या हो गया, हम सभी इसी से गुजरे हैं, हमने भी ऐसी ही ट्रेनिंग की थी, हम भी ऐसे स्ट्रेस होते थे. तो ऐसी अब की जनरेशन को क्या प्रॉब्लम है? प्रॉब्लम ये है कि हमारी जनरेशन was being we were brought up like that the mental health is a taboo or a weakness. We found that the stress is somehow equivalent to endurance, and we have to bear, we have to be patient about the stress or so. But we were lucky enough to have a very strong family support, and we have even the religious support as a coping mechanism. What you may hear from the younger generation, they are more aware of mental health vocabulary. You may find a 6 or 7 year old kid saying, मुझे डिप्रेशन हो रहा है, मुझे एंजाइटी हो रही है, मैं बोर हो रहा हूँ. You can say the age we do not expect this sort of language from that kids. And then they are more open for anxiety, depression, burnout, and they do have dopamine drain. Dopamine drain is actually, you can say, when you see the screen, there would be release of dopamine, and dopamine gives you some sort of rewarding, or you can say a sort of small win. But repeated or overstimulation with screen will then result in dopamine drain. And then you feel boredom, and you need a reset. You have a reset of your brain for that rewarding mechanism, and you cannot get happiness or so with small activities. Okay, so keeping in mind these differences, we should be very mindful. Yes, this generation is more aware for mental health problem, but they do not cope, and we all know that they are overwhelmed with a constant state of exposure and comparison. So they cannot actually they cannot stand with the mental health problems or even with the small stress. So what can we do? Should we wait for the government to take care of these psychological issues or so? Do we really think that in our setups with the available sources, government can do everything? And the answer, I guess, would be no. We have to do something in our capacity. What we can do with our identity of a teacher, with an identity of a parent, with an identity of a caregiver, because our patients are from the same society. We are looking after the same patient. The burden of PCO, the burden of infertility with the same Gen Z. So what can we do? We can do what is in our hand is actually we can offer help. Seeking help is a sign of strength. Another thing which we can do, as you can say that we are a part of MBBS program, as a teacher, what we can offer is that you can facilitate early discussion, reduce stigma around the sensitive label, and create a safe space for expression. And when you are caring or looking after the postgraduate resident, you must be mindful. In addition to the point of MBBS, you should be mindful for their working hour, if they are having any sort of burnout. And I always feel that being involved in clinical training, we are as a role models. So we have to perform a healthy role modeling for work-life balance and self-care practices. And then as a family, yes, allow an open conversation, plus allow the activities that actually help to combat with this dopamine balance, and all the social interaction of physical activities, and a combination of physical activity, social interaction, and then screen time can actually help in regulating this dopamine release, and the student can work. And as then at the level of institution, we personally have witnessed the journey of University of Lahore for having mentoring programs and then well-being programs. So the tag of these well-being programs offer actually liberty for even faculty to attend these training, these activities. They can go there, and we recently have this UL well-being week, and there were we were already discussing, there were very physical sort of activities and painting and etc. That can help to reduce the stress. And then we should have trainings for stress management, and these trainings should be even offered to the non-medical students also. Another thing, the last, we feel that we as an educators are the first responders. So we should learn how to respond to a stressed student. So that's why this training came in, and we actually learned from Dr. Nabha that what is psychological first aid, and what we as a trainer, we as an educator should learn, or even we should learn as a caregiver. Because the specialty, especially I deal, we do see the patient of infertility, we do see the patient of PCO, we have the girls with difficult weight management. So even at times they are stressed out. So we should learn this, and I personally feel it should be a series of workshop with this training. Then there is another training that is called question, persuade, refer, the QPR training, the same training for suicide prevention as we say CPR. And then obviously, as it's linked to the social media use, then there should be training for effective use of social media, the social this digital professionalism and digital well-being. Okay, with this, over to Dr. Nabha, and she will actually tell us how to do this first aid.
Thank you, Professor Saima Rafiq. Over to you, Dr. Nabha Naqvi.
जी सर.
थोड़ा सा अपना तारुफ करा दें बेटा.
जी सर, बिल्कुल. Yes. Actually, I have changed my laptop and I'm not used to of it.
Do you need any help, Nabha? I can share for you.
All right. I'm all right. Assalamu alaikum everyone. Assalamu alaikum Dr. Mulazim, Dr. Saima, Dr. Salma Kundi, and Dr. Saima Batul. I'm Nabha Batul Naqvi, and currently I'm working in UK as a special education needs teacher and as a well-being practitioner in a well-known school in UK, which is like related, which typically manages special education needs kids. So ये जो टॉपिक है साइकोलॉजिकल फर्स्ट एड का, जब रिसेंटली लास्ट जब 2 इंसिडेंसेस हुए थे सुसाइड के स्पेसिफिकली पाकिस्तान में, जिसकी बहुत ज़्यादा हाइप क्रिएट हुई थी, और इसके बाद बहुत ज़्यादा वो सोशल मीडिया पे जो है वो उनको दिखाया गया था. एट दैट टाइम me and Dr. Saima we discussed that we need to do like some sort of workshop or some sort of training related to this. So at that time, this idea of psychological first aid like developed. So psychological first aid is basically similar to
नाबका इसको पावर पॉइंट पे कर लो ना, बट स्लाइड मोड पे कर लें.
जी जी
नो, इट्स गुड, थैंक यू सो मच.
अ, तो उस वक्त हमने जब बेसिकली साइकोलॉजिकल फर्स्ट एड जो है इट इज़ सिमिलर टू फर्स्ट एड ट्रेनिंग जो कि हम लोग जो है वो जब फिजिकल प्रॉब्लम से रिलेटेड जो है वो हम यूज़ करते हैं. लेट्स स्टार्ट. सो आज के हमारे सेशन ऑब्जेक्टिव्स होंगे कि हम लोग साइन ऑफ स्टूडेंट डिस्ट्रेस जो है उसको रिकग्नाइज करेंगे, जो कि डॉक्टर साइमा ने ऑलरेडी जो है बहुत अच्छे तरीके से एक्सप्लेन कर दिया. बेसिक प्रिंसिपल्स ऑफ साइकोलॉजिकल फर्स्ट एड क्या है इनके बारे में डिस्कस करेंगे. सपोर्टिव कम्युनिकेशन हम कैसे यूज़ कर सकते हैं. Identify the high risk indicators that will definitely require escalation and how we will be escalating students, what pathway we will be using, and signposting students safely and appropriately. I don't know what is happening to this presentation, but I'm not doing anything.
कि आप दोबारा
Please
इसको
share with me. I
दोबारा
will
शेयर
share the
करें.
slide for you.
There we go.
हाँ, ठीक है, ठीक है.
Yeah.
नाबिहा नजर आ रहा है. सेशन ऑब्जेक्टिव्स हैं, आप शुरू हो जाएं. बिस्मिल्लाह
जी
कर लें.
जी. तो साइकोलॉजिकल फर्स्ट एड क्यों मैटर करती है. As a university staff, as we have discussed before, that teachers will be the first point of contact. For distressed students, many students do not initially seek formal mental health support because, like, due to the fear of stigma, due to the fear of um, being कि उनका बहुत ज़्यादा मजाक बनाया जाएगा, या फिर ये है कि बहुत ज़्यादा जब आपके स्टूडेंट्स के पास ऑलरेडी स्टडीज़ का बहुत ज़्यादा बर्डन है, सो दे डोंट गेट टाइम टू गेट टू अ साइकोलॉजिस्ट टू अटेंड सेशंस. सो एट दैट टाइम साइकोलॉजिकल फर्स्ट एड जो है वो बहुत ज़्यादा इंपॉर्टेंट होगी. Calm, supportive early response, which can reduce escalation and encourage help seeking. Staffs are not expected to basically provide therapy, but they will be the first responders. So you need not to fix anything, and we will not try to fix anything while doing psychological first aid, but our response matters. High risk indicators when psychological first aid became critical is if the student is saying that I don't want to continue my studies, what is the point of living in this world? Sudden disengagement, if you are seeing the sudden disengagement in your students, that he's being disengaged from the social activities, from classroom, from their normal functioning. And then if there is a mention of self-harm, whether you witness it or whether it is being told by the student or anyone related to it, that times PFA will become critical. PFA क्या है or what PFA is? It's basically immediate psychological support, stabilization, and connection, and then it's not a therapy. What are the main aims of PFA? So same as we do in first aid, that preserve, prevent, and promote. Similar will be the aims of PFA. The first is to preserve life. We're trying to preserve life. We're trying to preserve the quality of life of an individual. And then next is to prevent escalation. प्रॉब्लम एस्केलेट ना करे और उसके जो है वो इंक्रीज ना आए, सो वील बी प्रिवेंटिंग दैट. एंड देन इट्स प्रमोट रिकवरी, providing comfort, and meanwhile we are raising awareness about the mental health issues and that they can be treated and we can manage them. And then last is reduce stigma that Dr. Saima has already discussed really well.
Uh,
What PFA is not. It's not a diagnosis, it's not counseling or therapy, it's not a long term care, or we can use it for the long term, like we can use it as a long term treatment plan. It's not pressure to disclose personal details, and it is not trying to solve every problem immediately. The core model, or the model we are going to use for psychological first aid, is look, listen, and link. So first case, look. What are we looking at? We'll be looking at the risk. What are the risk factors of a particular issue if a student comes to you, or like any patient is coming to you with, and you suspect that he's going through some sort of mental health issue, then what are the risk factors? And what could be the risk? Like, will it be risking his life? So first case, to look for it. Second is distress level that will be evident by his or her body language, facial expressions can help. And third is functioning. So what kind of appearance a particular individual have, like कहीं उसकी जो है वो ड्रेसिंग सेंस में चेंजेस तो नहीं आ गए, उसका जो है वो बिहेवियरल चेंजेस तो नहीं ऑब्जर्व कर रहे हैं आप लोग, क्लास में डिसएंगेज तो नहीं हो रहा क्लासरूम से, और हम कह सकते हैं कि लाइक और इफ इट्स अ पेशेंट, तो वो किस तरह की फिजिकल अपीयरेंस के साथ आया आपके पास. The second is listen. What we are listening. Listen without interruption. Don't interrupt the individual when he or she is trying to tell or share his or her problem. Use a calm tone. Reflect emotion. That I'm understanding what you are feeling. I can understand what you are going through. Validate students' experience. How you going to validate is, I can understand how difficult it is. And next is avoid judgment. Do not judge. Judgment would be like, this has happened to us before. Why are you not able to like and next and last is avoid rushing to the solutions. Immediately do not provide any kind of solution. Just try to listen and then try to support.
उसमें ना वो
Listening to the when you will be listening to your patient or your student at that time, you gonna rate his or her symptoms or in 3 categories, which is green, amber, and red. So green is distress, but functioning intact, no immediate risk. So आप उसके साथ डिस्कस कर सकते हैं, उसके साथ जो है वो उस प्रॉब्लम को जो है उसकी प्रॉब्लम को जो है वो बहुत ज़्यादा एक्सप्लोर करने की कोशिश करें। और इसके बाद उसको जो है आप साइन पोस्ट कर सकते हैं कि अगर आप चाहते हैं कि आप किसी भी साइकोलॉजिस्ट के साथ कांटेक्ट करें, या किसी साइकोलॉजिस्ट के साथ मैं आपका कांटेक्ट करा देती हूँ, या मैं आपको उसकी तरफ रेफर कर देती हूँ। Second is amber. Amber relates to persistent distress, reduced functioning, no immediate skill. We haven't got any immediate risk. But for amber signs, if you are suspecting someone to be in amber category, then you're gonna definitely signpost him or her to the psychologist. And third is red. So red is the urgency and risk, which we will be doing specifically for suicide and self-harm individuals. So for green, which we are categorizing as mild, link will be your decision point. So for green, you're gonna support, listen, and monitor. For amber, आप support करेंगे, monitor भी करेंगे, and then refer to the appropriate services. And for red, escalate immediately and ensure safety. For red, you will not be like delaying anything. आपको फौरन से जो है वो escalate करना है to proper individual, like to a psychologist or a psychiatrist. And if there is a risk of suicide, at that time आप confidentiality को जो है वो breach करेंगे, और फौरन जो है वो जो भी आपके आपके पास पाथवे है, जो कि आपने कोई भी पाथवे डिज़ाइन किया हुआ है कि किस तरह से जो है उस सारे रिस्क को रिपोर्ट करना है, आप फौरन जो है वो इमीडिएटली अथॉरिटी को रिपोर्ट करेंगे पर्टिकुलर रिस्क के बारे में, इफ सुसाइड और सेल्फ हार्म, टू एंश्योर द सेफ्टी ऑफ द इंडिविजुअल. So basically, look, listen, and link, they are not related to diagnosis, but we will be using it to decide the safest next step. हाई रिस्क इंडिकेटर्स क्या हो सकते हैं, जो कि जिन्हें हम रेड इंडिकेटर्स कहेंगे, और जिन्हें हम रेड जो है उससे लेबल करेंगे, वो हैं सुसाइडल थॉट्स और इंटेंट, डिस्क्लोजर ऑफ सेल्फ हार्म, और अगर आपने ऑब्जर्व भी कर लिया है कि, और अगर आप ये सस्पेक्ट भी कर रहे हैं कि पर्टिकुलर कोई भी इंडिविजुअल जो है वो सेल्फ हार्म का जो है वो हो सकता है. What is the point of living if a student comes to you saying this and I don't want to continue? If there is any risk present, a minor risk present, then safety comes before confidentiality. What is the most important part of psychological first aid is the supportive communication. So if you can just write in the chat which response will be more supportive, you will be fine, or B, that sound difficult, I'm glad you told me.
We are getting answers. Most of them are B. Nabra?
Yeah, yes, I can say it. And
Okay.
that's absolutely
Maka.
right. B is the most appropriate and the most supportive answer. So a good practice for communication will be calm tone, using open questions. Don't use leading or loaded questions. Leading questions will be आपको कहीं suicidal thoughts to nahi aati. This will be a leading question.
If our
Loaded question.
participants
Like,
are international, please keep the language English.
okay. Loaded questions could be like you are asking too many questions at the same time, and then minimizing statements. Minimizing statements could be like you will be fine, you are perfectly all right, this happens to everyone. Boundaries. What are the boundaries of a psychological first aider? So your role is to notice stress, respond calmly, listen supportively, assess immediate concern, and connect to the student help. But your role is not to diagnose, provide therapy, promise secrecy where safety risks, take sole responsibility for the student well being. Clear boundaries basically protect both the student and the staff member. Otherwise, you yourself will start feeling overburdened. What is a golden response formula, or when you like encounter an individual who requires a psychological first aid and you have to respond? So there is a golden response formula, which is acknowledge, validate, support, and refer. So according to the golden script, how are you going to respond to the indicators we have discussed before? So for green, you will acknowledge that sounds stressful. Validate, that's understandable, or I can understand what you are going through. Support, how have you been coping? What strategies have you been using for for coping to this stress? And then refer, support is available if needed, and then closely monitor. For amber, you will acknowledge like, I can hear this is affecting you. Validate, anyone would find it difficult. Support, I'm glad you told me, and now let's connect you to the support. For red, acknowledgement will be like, I'm really concerned hearing this, and I'm really concerned about you. Validate, that sounds incredibly difficult. Support, you are not alone. And refer, we need to get help now. Always avoid these kind of statements. You will be fine. Others have worse issues than yours. Just relax, giving quick solutions that, and never like assure any kind of solution to a particular individual. Like you're gonna say, I can solve your problem, or I'll do something to solve your problem. That could be a false reassurance on your side, and that can worsen the situation. Instead, we'll stay calm. We will validate the emotions. That I can understand what you are going through. Listen actively, maintain boundaries, and encourage help seeking. That if you are if a student comes to you with a mental health issue, always encourage help seeking. That if you want, I can refer you to the psychologist, or you can go to the psychologist yourself and seek help. Refer and escalate as required. Document and report is really important. So if a student is coming to you with any mental health problem or any issue, please document and report. Specifically document everything. It will help in the later. You don't need to fix everything, but your response can change everything. Referral and follow up. For referral and follow up, will be doing escalation, when to escalate, who to contact, and there needs to be an emergency pathway in every organization, linking to support, linking to the counseling services, well-being teams, crisis helplines, if there are any, and then follow up. Brief check-ins, documentation, as we have discussed before, and maintaining appropriate boundaries. What are the common mistakes? The common mistakes to avoid are jumping straight to the advice, minimizing students' feeling, trying to fix everything, which you can't or we can't, asking too many questions too quickly, becoming over-involved and delaying escalation when risk is present. A supportive, contained response is more helpful than an overly complex one. Meanwhile, your own self-care and your own well-being is really important. So recognize your own emotional responses, debrief appropriately when needed, know your own limits. So if you are going through, suppose you have lost someone recently, and a student comes to you, and that particular individual has lost his or her significant other, and he is distressed about that. At that time, there is a possibility that you yourself starts feeling more distress, or there could be a flashback of memories, and you might start experiencing negative emotions. So at that time, you need to know your limits. So you can refer that individual to any of your colleague. Seek support from colleagues or systems. Remember that you are not responsible for solving everything alone. Supporting further
Excuse
is
me,
also
Nabha.
self-awareness. Yes.
People are saying in the chat that your screen is not moving or the next slide is not there. Is
Uh-huh.
this the same slide you are describing, or you have gone far?
What the slide is, sorry.
Do this instead. The title
Around
is
the to
Do
do
This
this
Instead.
listed. Stay calm, listen actively, validate emotions.
Okay. Do this and scat. I have moved 2 slides. I'm moving it and it's moving on at my end.
Reshare, please.
Okay.
Can you restart and then reshare?
Are you all able to see it now?
Yes.
So shall I get back to the previous slide?
So just do the full screen.
Okay. So that was the next slide after do this instead.
It's okay.
Okay.
If you have described, you can move forward and go to the staff self-care. Yes, this one.
Are you all able to see it now? Okay, seek
Yes.
support from colleagues
Yes.
or
Yes.
and
Yes.
and remember that you are not responsible for solving everything alone, so you can take help. Supporting others also require professional self-awareness. So key takeaways from my presentations were distress among students is common. Staff are often the first point of contact. Psychological first aid is about support, stabilization, and connection. The core approach is look, listen, and link. Use the traffic light model to judge level of concern and know when to support, when to refer, and when to escalate. You are not expected to be a therapist or to provide a proper treatment protocol that is required for a individual with mental health issues, but you are expected to be the safe first responder for a particular, if a if a student comes to you with, or a patient comes to you with some mental health issue. Final reflection is how confident do you feel now after responding to a distressed student? And one key takeaway from this session.
मैंने आपको मना किया ना।
So
Thank you so much, Dr. Nabga. Very nice presentation, and we'll start question answer session. There are so many questions on this important topic, and I will request Professor Saima Batul.
Thank you, sir. Nabga, can you please stop sharing your presentation so that I can do? Thank you. Thank you so much for to Professor Mulazim
जी,
Bukhari
आपका
and
शुक्रिया
Professor
डॉक्टर
Salma
साइमान
Aslam
बतूल
Kundi
आपका
for giving us this opportunity. I am Professor Saima Batul Naqvi, and I am a professor of pediatrics at University College of Medicine and Dentistry, the University of Lahore, and also uh, a medical educationist. And I have been supervising medical education students, masters, for the last almost 10 years. And I'm also the director of continuous professional development, CPD activities of Medical Women Association of Pakistan. This is my brief introduction. I was asked to tell the perspective of a pediatrician regarding the psychological first aid. But before starting, I will just have 1 or 2 minutes to specially thank, you can say, the stalwarts of medical education who are here, especially my teacher, Professor Lubna Beg. Thank you so much, madam, for joining, for giving so much time. I want you to, I request you to just give few comments regarding the topic, because I know it is, you are very much interested and a very senior person in qualitative studies and educational psychology. So can you please share your comments before I start, madam?
Thank you very much, Saima, for putting me on the spot. I was just learning something, and I did. I mean, I think Saima Rafiq's presentation was amazing as well. I learned a lot from Nabra. I think, given the present situation across Pakistan, this is something where we really need to talk about psychologically safe spaces. Not only for the student, but also for the faculty. So that is why I especially appreciated when Nabgha's one of those slides she talked about, when we are listening to everybody, we have to be cautious of our own internal psychological environment at the same time, and we don't realize that the most neglected people are generally the faculty, because there's a lot of expectation and not much given to that. So I think something that I'm trying to work on right now with my students is how to build that resilience. Saima talked about in the beginning, and of course, I am way before all of you. In my times, the more stress was given to us during our MBBS, during our residency, particularly residency, especially if you're doing at places like AKU, it was expected the more stress is given, the more we are going to learn, no matter
Yes.
what was happening inside us. And some of us were married with children. So it was so taxing for us that we were
Yes.
unaware of our own emotions. And then, like it's more like some of those people, particularly of my era, still believe, which is so wrong, that they're going to learn. The more stress you give them, they're going to learn. That is so wrong. Yes, you have to make sure that the students are resilient and be able to manage stress. Giving a little bit pressure on how they need to learn how to learn. At the same time, we need to manage how Nabha has described, the PFA and how to look, listen, and link and things, those kinds of things. So, and some of us are doing that. So I think kudos to all of you, particularly having this webinar at this time. I was, my CHR had ended early today, so I was with that. And then I saw this message from Saima. She said, no, please join. And I'm so glad I joined. So thank you very much, Dr. Mulazim and Saim. My two lovely girls, Saima Batul, Saima Rafiq, are there. And of course, Nabra, you are, of course, another same person. And thank you so much. I really appreciate doing this. There's lots of research with intervention needs to be done. So I think that should be our next target. So see you all next week when I'm again in Lahore.
Thank you.
Thank you so much,
Professor
madam.
Lubna.
Thank
You
you.
are also my teacher, and you really, when I was I student, the stress was actually no doubt every students and every time there. But from the stress, I learned so many things due to this stress. And I think stress, if any student take in a positive direction, I think it is better, as Professor Lubna you told us. But I do not know how people are here. We will discuss because Dr. Zafar Tanveer is here. And due to
Sir, can I
topic,
proceed? We can
and
have
the incidents
at
happened
the end.
in his institution. That is an example. At the end, we will take all these questions and answer. Dr.
Thank
Saima,
you,
over
sir.
to you.
Thank you, sir. My presentation will be brief, so just bear with me for next 5 to 10 minutes maximum. So I have to give a pediatrician's perspective. And of course, as I am a medical educationist, so the touch will be there. So regarding the children, psychological safety is you can say much more important because children they are not able to describe their problems as much as the adults can do. Like our medical students are adults. So as a pediatrician, I come across these problems much more. And as a pediatrician, I have and all the rest of the pediatricians, there are few pediatricians over here who are among the participants. We have to put extra effort to just identify whether this child is having just a disease or is this complicated with the psychological problem as well. So this is basically a crisis. It's in a child, it is always not always loud, but maybe silent. So we have to pick. If you imagine a 7-year-old child, a parent, or a medical student suddenly starts crying when I am in OPD, what will be the first sentence I would say, or you would say first? What will be the first sentence that you would say? Can anybody share? Any one of you? Anyone among the participants? What is the first sentence? अगर कोई रोने लग जाए, the child or a parent or a medical student or anybody else comes to your office and starts crying suddenly, what will be your first sentence? First sentence to that person?
I will say, please have a seat, and I will offer them a glass of water, and then
Yes, you are a psychologist. Yes, you
Yes,
will
she should.
do that. I know. Anyone else?
I think what the teacher will ask. So many teachers are there.
Yes, you
Usually
can
the
tell me
students,
the teacher's perspective as well.
such incidents happen with the students.
अस्सलाम वालेकुम।
जी डॉक्टर आमना शाह।
सर मेरी प्रैक्टिस तो यही होती है कि जब अक्सर औकात बच्चे इस तरह स्ट्रेसफुल कंडीशन में आते हैं तो सबसे पहले तो हम उन्हें बिठाते हैं, उनकी सारी बात सुनते हैं कि हुआ क्या है। Particularly they are more concerned with the marks nowadays. The students are going with the mark that they should be having a good GPA, they should be having a first position. So I request them that position holder remains the one, and don't go and don't run with the GPAs. Study doesn't mean that you will be having a good GPA. It depends upon the skills. To develop the practical skills so that you may be live in your future.
Thank you, Dr. Amna. Now proceeding with, because we may be short of time, so what PFA is or psychological first aid is and what is not. Dr. Nabga has given you a brief overview of the this proper PFA concept. So I want to reiterate and reaffirm her that PFA is not psychotherapy. It's not a diagnosis and not forcing someone to talk. It is basically a calm, safe, practical first response after distress. And WHO has said that this is basically, as we know, that first aid has to be every person, even if he is not a medical person, should be well versed with the first aid. So do the psychological first aid. So WHO has said that PFA guidance emphasizes supportive and practical help after serious crisis event. So you do not have to preach or do not have to force anyone to talk. Just wait and see and follow the 3 steps which the Nabha has told you. Similarly, we do it in children. And when we look at the global perspective, the global child health and psychological first aid evidence, if we look at it almost throughout the sphere, starting from the north till the south, the different medical societies as well as the societies which are associated with the psychological problems, they reiterate that the psychological first aid is the mandatory skill which a person should know, a person should listen. And one of the things which I come across, which was new for me, that this concept of I was given of look, listen, and uh, link was given by the International Federation of Red Cross along with the WHO. And in the UAE and Middle East, they have labeled it as 800 Sakina. Sakina is the name given to it, and they said that they have made it, you can say, their helplines in which whenever a child with a psychological first aid is received, that particular helpline can be used to report that child with some psychological distress. So look, listen, and link apply to not only to the adults but also to the children. Same case which from which we started, that a 7-year-old child after an accident is quiet, refusing to speak, tightly holding the mother's dupatta, comes to your OPD. What do you look for? Yes, we look for safety, physical safety, because after the accident he may have some sort of trauma. So look for the safety and injury. Look for the caregiver presence, whether there is a caregiver along with the child or not. Then his immediate needs, he may look thirsty, he may look hungry, or there may be some degree of distress. So this is the first thing in a child to look for, because most of the time children can't speak for themselves. In the second thing, if we apply to the same 7-year-old, what we have to listen. We have to be all ears, because if I say, if I have just ensured the initial safety and looked at the safety of the surroundings of that child, what will be the first better sentence out of these two? Can anybody tell? Will you say A, don't cry, everything is fine? Or will you say B, I can see this is very difficult, I'm here with you? Can anybody of you, very easy, which one will you choose? Anyone from the participants?
B.
B, very right, thank you. B is the safest, B is the best option or the better option out of these two, because children, they may won't stop crying just after
Is
saying
this
that
a
don't
part of
cry or everything
empathy,
is safe.
Dr. Sam? Is this a B is
It's
like
not part of
empathy?
empathy, sir. You can, yes, a bit of empathy you can say, but it's part of the active listening, basically. Active listening is a process itself. So active listening is just not sitting in front of a person and listening whatever he's saying. It is basically an active process so that the other person understands, or by looking at you, just by looking at you, that you are all ears. You are not using your mobile or looking at some the child is talking, and if I am looking at some other area or some other side or writing something, that person or that child will not be able to share his or her experience with me. So that is the active listening. And last one is the component of look, listen, and link. For this child, we have to look for certain red flags, and we have to avoid, for example, if we find that there is a self-harm talk, like Nabga has said, we have to categorize that particular child into the red category. अगर वो कहे, if a child says that I am going to kill myself, even the small children, they do talk like this nowadays. So that is another thing. So this is the child who has to be kept in the red category and referred as early as possible. So if we combine all these, it's, you can say, the psychological first aid, 3L, or look, listen, link, is basically an early, humane, practical support for a child. And children, as just a summary, that children do not always say I'm distressed. You have to look at it's just like um, uh, this iceberg. You don't have to see the tip. There are many things which are under the water. So we have, as a pediatrician, we have to look for these as well. You are safe. I am here. Take your time. These are the things we usually say to children. What will you do first? Ask detailed questions now. After 1 minute has gone, the child has taken deep breath. We can ask, and we do ask like this. Tell the child not to worry, sit calmly and ensure safety, and call the parent irresponsible. Out of these, the which one will you choose in the first minute? लिखा हुआ है वैसे तो आंसर is already there, the C answer. Sit calmly and
Sit calm and
ensure
ensure safety.
safety. Yes, thank you. And also look that if
Thank you,
the
Arif.
parent or the caregiver is distressed, so we have to keep it in mind as well. So psychological safety prescription for a child is not for it doesn't contain any drugs. It contains certain words which reassure that the child will think that he is safe and he will be taken care of. And as we know, that child abuse and child neglect is itself a big field, evolving field, still evolving in Pakistan. And we have various child protection agencies across Pakistan, and also different NGOs working. These are the references which I have used for my presentation.